I went to a meeting last night and of various physicians and clergy, and I was very disappointed to see what some of those people look like. But today we're going to learn about 2 ways to get your weight down and keep it down. One, diet, and if you can't do that, bariatric surgery, which is really very successful these days. We're going to start off with Dr. Joel Ricci Gorbea, who is not only a great bariatric surgeon, but a terrific surgeon in general. If you really need surgery, if you got a big belly ache or anything like that, do not pass go. Go to the ER at NYPQ. You'll get treated better there than you will anywhere else. Dr. Gorbea.
Thank you, Dr. Bright. So, like Dr. Bright said, I'm Dr. Ricci Gorbea. I'm one of the bariatric surgeons at NYP Queens. We're going to talk about weight loss surgery. I'm going to keep it short and simple. I'm going to give you some pointers of why obesity is bad for you, what it does to your body, what it will eventually do to your body, and then why surgery has become the standard of care for obesity as a tool. Can you hear me better?
It's not on back yet. Is it on?
No?
Now it is.
Okay. Like I said, so we'll use surgery as a tool for helping you lose weight, not as a cure for obesity per se, but as a tool. And that's the most important thing that I want you to take home today, is that we can help you as surgeons achieve your weight loss goals, but at the end of the day, you have to help yourself with the things that you have to do adjacent to surgery, additional to surgery, in order to achieve a weight loss goal. The other partner in the group is Dr. Merola. He's the director of the group. He's been in NYP Queens for a long time. Between him and me, we've been there for over 15 years.
He was here, wow, first year.
Yes. So having said that, obesity and the medical diseases that are related to weight per se. Anything from pulmonary disease, a normal function of the vascular system, obstructive sleep apnea, which is a sleep disorder where you snore a lot, you have shortness of breath when you're trying to sleep, you don't get enough rest, you wake up at night. Non-alcoholic fatty liver disease, so when you hear people have fatty livers and they're not alcoholics, it's usually because of obesity. Cirrhosis, gallbladder disease, coronary artery disease, which leads to myocardial infarcts or heart attacks, diabetes, pancreatitis, some types of cancers like breast, uterus, cervix, colon, pancreas, and esophagus, polycystic ovarian syndrome in young ladies, skin problems, arthritis, gout, venous stasis, which is the varicose veins that a lot of women suffer from, and men too. All of these are related somehow to obesity, and the more weight you gain, the worse these diseases can get. In terms of conventional therapies for weight loss, for years we have treated weight loss with diet and exercise. So it's all behavioral modifications. You go to your doctor, they tell you you have to lose weight. And your next question is, how do I do that? And a lot of people don't know how to do that, because the reality is there's a lot of times where you get rebound weight gain. So you lose the weight initially, let's say you lose 20 pounds by doing diet and exercise, but then you go back to your regular habits of eating and you gain 30, 40 pounds. There's a way to maintain the weight that you lose, but it's a lot of hard work, and a lot of people don't achieve it. Only 3 to 5% of the people that actually lose some significant weight are able to maintain it past the first or second year. And that's significant. That's why surgery became the standard of care, because we as surgeons, we're not going to guarantee that you can maintain the weight, but if you do the things that we tell you to do after the surgery, it's pretty much a guarantee. You can maintain the weight lost for a long time, and it can actually increase your life expectancy for over 15 years. What that means is, if you're 50 years old now, 40 years old, and you're expected to live 10 years because you're obese and you have a lot of problems related to obesity, if you lose the weight with the surgery, that expectancy goes from 10 to probably 20 years, probably 25 years, that you're gonna live more and live longer. That's significant. That means that we are preventing you from becoming more ill due to the obesity. Like I said, this is a tool, it's not a cure for obesity. The obesity has a lot of factors that contribute to it. Most of it is behavioral. There might be some genetic components, there might be some stress components, metabolic components, but the plain and simple answer to why people gain weight is because of behavior. Behavior towards food, undisciplined towards exercising, and if you put that together into a disciplined regimen where you eat well, eat healthy, exercise, and the surgery on top of that, then you can achieve a lot of weight loss and maintain it long term. I'm gonna do a little bit of an overview of how digestion occurs. It's gonna be very short. We eat, ingested food through our mouth, it goes down, where's the pointer? It goes down the esophagus, down into your stomach, and then it gets digested into the intestine where it travels towards the colon, becomes stool, and then it gets evacuated through the rectum and the anus. Okay, that's the way food goes. The reason I'm explaining to you this is because the surgeries alter the way that the food enters the stomach and exits it. The gastric bypass is one of the choices that we have as options for bariatric surgery. It's been around for over 40 years, maybe more, and it's been demonstrated nationwide and worldwide to be the best option possible to lose weight. You might have heard people in your family, friends that you know that had a gastric bypass, and some of them had great experiences, some of them might have not had great experiences. I'll explain to you how it works, and then I'll explain to you another operation that we do that has become more common and a little bit safer. In the gastric bypass, we cut the stomach into a pouch that is the size of an apple, maybe the size of your closed fist. This stomach is left behind. It's still in your body, but it's completely bypassed from the new pouch, which is this portion here, the new stomach, into the intestine by bypassing the area where all of the bad sugars, the bad fats, and the bad nutrients get absorbed. Okay? This part of the intestine gets reattached downstream into the channel where the food comes through in order for the juices from the stomach and the pancreas and the gallbladder and the liver to enter the intestine, mix all the food, and help the digestion. Is that clear? Okay. How we do it is by cutting the stomach, creating the pouch, we cut the intestine a little bit further down, and then we bring this loop of intestine up here, and then this loop of intestine goes down here. What that does, it prevents you from overeating because the pouch is too small for you to overeat. So imagine a plate of food that you eat at a restaurant right now, cut it into five portions. You're going to be able to ingest maybe one of those 5 portions. What that does, it helps you ingest less calories. And on top of that, by bypassing this portion of the intestine and this portion of the stomach, you absorb less of the bad nutrients, the bad sugars, and the bad calories. So the gastric bypass has a dual way of working. It restricts the amount of calories that you eat, and it restricts the amount of calories that you absorb. Okay? So it has a restrictive capacity and malabsorptive capacity. That's why it works so well. Now, it might have a little bit of a downfall when it comes to absorbing nutrients and vitamins, and that's why you have to be on a multivitamin and nutrient supplementation for life after the bypass, because there are certain nutrients that are essential for your daily diet and for a healthy diet that need to be supplemented because they don't get absorbed due to the bypass. Okay? Now there's another option that has become more popular over the last 20 years. It's called the sleep gastrectomy. It's a little bit less invasive, and it only consists of cutting the stomach into a banana shape. And that's what we call it a sleeve, because it looks like a sleeve. And this portion of the stomach becomes useless, so we take it out. Okay? What happens is it restricts the amount of food that you can ingest. That's the only thing the sleeve does. It restricts the amount of food that you ingest. It doesn't have the other action of not absorbing the calories. But surgeons, in about the last 10, 15 years, we found out that the sleeve works as well as the bypass. And it has less complications because it doesn't prevent you from absorbing those nutrients that we were talking about earlier. So it prevents you from overeating. You get full very quickly with a small amount of food. And if you follow the diet that we give you and do some exercise, you can lose up to 70% of the excess weight that you have. So if you're overweight by 100 pounds, you can lose 70 pounds with a sleeve gastrectomy, or up to 70 pounds. That's significant. What's expected in terms of weight loss is by month 18, about a year and a half after surgery, people can lose about 80% of their excess body weight. So 80 out of every 100 pounds that you have of excess weight, you can lose. What happens to the other illnesses that I mentioned on the first slide? They all get better. The high blood pressure gets better. Diabetes gets much better. You can get off of insulin or off of medications and control the diabetes with just diet. The venous stasis or the varicose veins get better. Everything from reflux to metabolic syndrome to high cholesterol to sleep apnea, all of it has been demonstrated to get better with the weight loss surgery. Especially diabetes. That's the big one, because diabetes, if you don't control it early on, it will affect your kidneys, it will affect your heart, it will affect your eyesight. It can affect anything in your body, and if you control it and kind of like try to get off of the insulin and the medications, your life expectancy improves by a lot. Just some things that I want to touch on in terms of what to expect with the surgery. The surgery is not ambulatory, but you stay in the hospital for maybe 1 day, sometimes 2 if it's a bypass. We expect you to walk the day of surgery. We start you on a liquid diet right after the operation that same night. You start drinking a little bit, 2 ounces every hour, then progressively get more. The first week after the surgery is a liquid diet, and then transition to a more soft and puree diet as the days go by. This is done for the stomach to decrease the swelling that comes with the operation. Phase 3, which is about 3 weeks after surgery, you go on a regular diet. And by regular diet, I mean it's a diet that we recommend with the help of our clinical dietitian, which is Mia. She's going to speak to you about diet later on. And we make a plan for you, and we help you. If you have questions, you can call us. If you have questions about what exercise are you able to do, you can call us. And the most important thing is that we need to see you every month and every 3 months for the first year. And then afterwards, so every year thereafter. You become my patient or Dr. Morola's patient for life. And that's the most important thing, because if you do that, we can guarantee you that you will lose and maintain your weight loss for a long, long time. The criteria for surgery, who qualifies for the operation? A good rule of thumb is anybody with 100 pounds overweight qualifies for the surgery. Okay? And then anybody that has about 60 to 70 pounds overweight, but has an additional illness related to obesity, either high blood pressure, diabetes, high cholesterol, or sleep apnea. We go by something called BMI. It's called body mass index. That's a measurement of your height versus your weight. The shorter you are, the bigger you are, the higher your BMI is. The taller you are, the BMI decreases because you can tolerate more weight. So anybody with a BMI of over 40 qualifies for surgery. Anybody with a BMI of 35, if they have an illness related to obesity, like diabetes, high blood pressure, cholesterol, or sleep apnea, then they can qualify. You have to have had some sort of history of previously failed attempts. If you tried diets before, and I'm sure a lot of people that are overweight or obese have tried many, many diets before, that also qualifies you for surgery if you meet the other criteria. And you must not have any psychiatric disorders. We have you screened by a psychiatrist prior to surgery. And the reason we do that is because we have to make sure that patients are of sound mind to follow the rules and the instructions after the surgery. It's not an easy procedure or it's not easy rules to follow because it's a full modification of your former behavior that needs to be modified in order to lose the weight and maintain it. And lastly, there's a step-by-step process that we go by. This is not us, this is required by insurance companies. They require 6 months of consecutive visits with your primary doctor. This is important because if you fail one visit, the insurance doesn't qualify. So you have to go straight visits every month to see your primary doctor. They have to weigh you and they have to give you weight loss counsel. Document that and send it to us. In addition to that, you have to see a cardiologist, a pulmonologist, a gastroenterologist, and a nutritionist, plus the psychiatrist that I mentioned before. It's a little bit of a long process. We are hoping that the insurance companies will change it somehow in the near future because sometimes patients get discouraged by these long processes. But if you abide by it and you do it, we're telling you, we have over 95% success rate in terms of patient satisfaction. And when it comes to weight loss, pretty much everybody loses weight. At different rates, but everybody loses weight. Okay, so the keys to success. At Presbyterian Queens, we have a very dedicated expert team of surgeons and a medical staff and nutritional staff that will help you lose the weight and maintain it. We're going to do a careful and complete examination and evaluation of your current state. You have to understand this is a tool, this is not a cure. This is something that we will provide you with, that we know works. It's been proven worldwide that it works. And if you work with us and we work with you, we can assume success. Regular exercise and good eating habits are essential, and Millan is going to touch a little bit more on that. And of course the follow-up, that's the most important thing. Once you become our patient, you become our patient for life. The reason is, most patients that are obese have that behavior of going back to food, or using food maybe as a stress reliever, or somehow they fall off the rails. And the reason we want you to follow up with us is because we can get you back on track. If you feel like you're becoming a little bit undisciplined, come back and see us. We can put you back on track. We have support groups. There are websites that you can look for. And there's a lot of support because we know this is difficult. We don't think this is easy, and we don't try to assume that it's easy. But there is a lot of support for you to achieve success. Yeah, I don't take any questions now.
I know that there's a procedure with a balloon.
Yes.
Could you tell us a little bit about
We currently don't do it at the hospital. We are working towards incorporating into our options. The problem with the balloon is that the balloon is a procedure that is out of pocket. It's paid out of pocket. It's not approved by insurance companies. So in order to make it more available for patients, they need to understand that they have to pay out of pocket.
But it's less invasive.
It's a little bit less invasive. It's also not for everybody. It's a procedure that is temporary, for temporary weight loss that is hard to maintain afterwards. But for the right person, we usually recommend it if it's a person that we think will benefit. And by that I mean somebody that may have to lose only 30, 40 pounds. Yes, sir.
But you call sleeve surgery, that's the same as band surgery?
No. The lap band used to be more popular about 10 years ago. With time, it has become less popular because it has a lot of complications. So we don't do the band anymore. We actually take more bands that we put in. We don't put any bands anymore. We used to. But we realized that the bands, long term, they're not a good option. They cause a lot of problems because they can erode into your stomach. They can cause reflux. you have a foreign body in your system, the port turns around in your skin. So there are places that still put bands in. In my opinion, and in Dr. Merola's opinion, we don't think the band works very well.
Okay, and, like you mentioned that when you do sleeve surgery, that you take out the rest of the stomach.
Yes.
How about when you do the bypass surgery, you just leave it in, or?
Yes, the bypass, what we call the stomach remnant, it stays in the stomach.
Does it cause any problems because it's not being used, but it's?
No, because it still produces acid and it still has some function, but it's not defunctionalized. And the bypass can be reversed. The sleeve cannot be reversed. So by leaving the stomach behind, if the patient for whatever reason does not tolerate the bypass, it can always be, it could be reversed.
And I've got a friend who had some type of surgery done about 4 or 5 years ago. He's as fat as ever now. What options does he have? Go back to his doctor and try to get back into the regimen again, or is it too late because
Well, it depends.
he had surgery done and they can't do anything?
It depends. It depends what surgery he had. It depends if the surgeon sees him as a possible candidate for revision. There's a lot of things that go into play with that. I personally don't think that revisions are for everybody. And by revision, I mean redoing a surgery. Because if you fail the first operation, chances are, and this is backed up by literature, chances are that you might fail the second one too.
Thank you very much.
You're welcome. Any other questions? So I'll leave it up to me.